Hello, everybody. I'm David Casey. I'm a psychiatrist. My specialty is geriatrics. Probably seen one or two of you at various times during your medical training before. Today, my task is to talk about mood disorders, and this is an introductory lecture. I doubt there's anything I'm going to say that you haven't heard at some point in your medical training before, so this should hopefully be in the form of a review, and I think Dr. Spurgeon will follow up this lecture and talk a little bit about case-based material. So my task is to give you some lecture information to begin with. Can you guys hear me okay? Good. So by way of an introduction, the first mood disorders we'll talk about are the depressive disorders, and you can divvy up mood disorders in lots of different ways. For convenience today, not because I think this is necessarily the best way to do it, but it's a convenient way to do it, we'll follow the format that's in the DSM, the Diagnostic and Statistical Manual, the so-called DSM-4. And some of you may know that the DSM-4 or the DSM-4-TR, which we have now, is about to be replaced. In May, DSM-5 is going to be introduced. And we're given to believe that there won't be a lot of change in DSM-5, but we haven't actually seen the final version yet, so it's a work in progress. The DSM-4 categories that we're currently working with under mood disorders include major depressive disorder, dysthymic disorder, sometimes called dysthymia, minor depression, which is not an official diagnostic category, but is sort of in our appendix, you might say, but it's worth commenting on, and mood disorder due to a general medical condition. We'll also talk about bipolar disorder, including bipolar I disorder, bipolar II disorder, and cyclothymic disorder. The yearly prevalence of major disorder, which is the most significant form of mood disorder, is about 2 to 5%, depending on the group that you're looking at and how the survey is done. So it's a highly prevalent condition. Lifetime prevalence is higher. It's about up to 21% in women and 13% in men. And every study shows that major depression is more common in women. The typical age of onset is in the 20s, but in fact, you can have onset of major depression at any time in life. About 50% of the people who have a depressive episode will never have another episode. The other 50% are apt to have recurrent episodes, and they are, in a sense, self-fulfilling. That is, the more episodes you have, the more likely it is that you'll go on and have more episodes in the future. So the DSM-4-TR it's the Chinese menu approach, the objective type of diagnosis, and it's based on criteria, and those include the presence of a persistent sad or depressed mood, or loss of interest or pleasure in previously enjoyed or enjoyable activities, at least one of those two, combined with 4 additional symptoms for at least a 2-week period of time. So this approach to diagnosis is useful in that it gives us something that is somewhat objective to follow, but it's far from perfect. You know, for instance, if someone shows up in your office and they've had depression for 13 days, you can't diagnose major depression if you follow this literally. The next day you could. Obviously, they haven't developed a new illness in one day. It's a consequence of this form of diagnosis. DSM lists physical symptoms, including sleep disturbance, too much or too little, loss of energy or fatigue, appetite disturbance or weight change, too much or too little, changes in activity level, psychomotor retardation or agitation, and also changes in the thinking process. That includes difficulty concentrating, thinking, or remembering or making decisions, feelings of worthlessness, guilt, or hopelessness, and recurrent thoughts of death or suicide. Untreated, the average duration of a first episode is 6 to 9 months, but they often recur, as I indicated earlier. And a person who's had 1 episode has about a 50-50 chance of having 2. A person who's had 2 episodes has about a 60% chance of having a 3rd. Somebody who's had a 3rd episode has about a 9% chance of having a 4th. And many patients that we see have developed many recurrences or even a chronic pattern. Dysthymic disorder or dysthymia is less severe but more chronic, sometimes called chronic low-grade depression. That includes a depressed mood plus at least 2 additional symptoms: poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration or difficulty making decisions, and feelings of hopelessness. So the same basic range of symptoms that you may see for major depression, but it's more chronic and less intense. Fewer symptoms are required. You can also have chronic major depression, a person that consistently meets the major depressive criteria over a long period of time. And in order to be diagnosed with dysthymia, the person has to have been ill for at least 2 years and never without symptoms for longer than 2 months. You can also have both things. The person who has dysthymic disorder with episodes of major depression superimposed, sometimes called double depression, and this is more difficult to treat and the prognosis is more negative. In geriatrics, we see a large number of people that have what appears to be major depression, but when you parse out the symptoms, they don't quite meet the diagnostic criteria. So it acts like major depression, it looks like major depression, but a very sort of literal-minded approach to diagnosis would suggest that you can't use the diagnostic criteria, and the term minor depression has been created for this. The research that's come out in the last few years suggests that minor depression is major depression under a different name. It acts the same way, it needs to be treated the same way, it has the same implications for treatment, and in the future perhaps our diagnostic criteria will be tweaked to incorporate this under major depression, but I don't think that's going to happen in DSM-5. As a geriatrician, I wanted to talk a little bit about some aspects of medical illness and aging that are obviously relevant to internal medicine, and that is it's very easy to overlook depression in the medically ill patient. When a person is ill or in pain or both, that becomes the focus of treatment, and it's easy to rationalize a depressed mood as a normal response to the stress of being ill. And that may be true, but when the person meets the diagnostic criteria for major depression, even if they're medically ill, most of our research suggests that that person has developed an additional problem. They have depression with whatever medical condition they have, and it's worthwhile to consider treating them. In terms of the aging process, you can make the same observation. Depression is not a normal part of aging, but it's often associated with the multiple stressors common to elders, such as loss, illness, etc. Some of you may have seen this written about. This has been one of the most controversial changes that's been incorporated into DSM-5, and it has to do with grief and depression. Grief following a major loss obviously is normal, and functional impairment and grief usually lasts less than 2 months in most cases. Sadness comes in waves, and prolonged persistent sadness, especially coupled with hopelessness, guilt, thoughts of death, and other depressive symptoms, suggest that a depressive illness has developed. If you read carefully the DSM-4 criteria for depression, at the very end there is a little paragraph, you might say, that's called the Bereavement Exclusion. And this basically says that when an individual has had the death of a close family member and they have a grief reaction following that death, you can't make a diagnosis of major depression until at least 2 months have passed. That's so that we don't over-diagnose depression in a person with bereavement. Well, it turns out that this is more complicated than it first appears, because doing away with the bereavement exclusion will mean that we may overdiagnose depression in people that have a normal grief reaction. Leaving it the way it is means that there's a certain number of people that clearly have major depression that can't be accurately diagnosed in our current nomenclature. And so the decision was made, a very controversial decision, in fact, to do away with the bereavement exclusion, and we're given to believe that it will not appear in DSM-5. Older people have certain symptoms that commonly occur with depression. These include a preoccupation with bodily function, for instance, constipation, pain, insomnia, or fatigue, multiple diffuse symptoms, sometimes called elder failure to thrive or adult failure to thrive, weight loss, anxiety, obsessional thinking, difficulty making decisions, and negativity. Preoccupation with finances, the person who fears they're going to run out of money, whether that is objectively true or not. And the loss of function in major depression in older people is quite similar to a severe medical illness. It's on a par with heart disease, cancer, Parkinson's, and the like. Some older people develop what's called melancholia, that is a loss of interest in interactions, marked psychomotor changes. And a person with melancholia, their mood is lost its responsivity. That is, they feel bad all the time regardless of what happens. Something good happens, they win the lottery, they don't really feel any better. That's melancholia. And some people develop executive cognitive dysfunction. That is, they can't accurately plan, make decisions, or solve problems. Long list of medical conditions that are associated with depressive symptoms, which may or may not be major depression. Those include ischemic heart disease, and depression contributes to both morbidity and mortality, and the effects are bidirectional. That is, the depressed person is more likely to develop coronary artery disease, congestive heart failure, and a person with heart disease who has major depression is more likely to develop a variety of symptoms and is more likely to die of their heart disease. Likewise, stroke, various kinds of cancer, particularly cancers that have some kind of glandular tissue, pancreatic cancer, lung cancer, stomach cancer, colon cancer. Those cancers are particularly likely to have depression, not just as a consequence of the fear or pain or concern or disability of the cancer itself, but something that's more akin to a paraneoplastic syndrome. That is, even a person that's not yet aware that they have cancer may develop depression as a consequence. And that's particularly true for pancreatic cancer and small cell or O-cell cancer of the lung. Neurological diseases like Alzheimer's and Parkinson's, chronic pain problems like arthritis, and COPD, all strongly associated with depression. The endocrine system is particularly important to look at. Hypothyroidism, problems in the HPA axis are all related to depressive symptoms. Depressed patients are very heavy utilizers of general medical care, so if you're in an outpatient setting, a large number of people who come to see you in the clinic are likely to have some kind of psychiatric issue or overlay related to their general medical care needs, and a significant number of doctor visits are ostensibly for physical symptoms actually related to depression. And once again, the interaction between depression and medical illness goes in both directions. Many medications have effects on mood. The effects may or may not reach the level of a major depression, but are still important to consider. Antineoplastic drugs, corticosteroids, which can be associated with depression or sometimes with mania. Antiparkinsonians, metoclopramide or Reglan, interferon. The last hour I spent with a person who's been taking interferon, and it's wreaked havoc on her mood. Obviously, alcohol, a variety of heart and blood pressure agents, and of course, opioids. Opioids are a very complex question because people with pain are very apt to become depressed, and narcotic pain medicine may have a beneficial effect on mood in a case like that. On the other hand, their direct pharmacologic effects tend to be more depressogenic, and possibly many others. Since I'm a geriatrician, I wanted to talk a little bit about suicide in the elderly. Elders have a high rate of suicide, roughly twice the rate of the general population. We've done several studies here in Louisville that confirm that that's true here. Males predominate in completed suicide, especially Caucasians, far out of proportion to their numbers in the population. And elderly men, when they set out to commit suicide, typically choose a highly lethal means, for instance, gunshot instead of overdose. And so they're less likely to survive, show up in the ER, show up on the inpatient psych unit or the like. And it's important to ask about suicidal thinking when you're evaluating a depressed person, particularly a person that you believe may be in a vulnerable position, such as an older gentleman. And persons who commit suicide have often visited a primary care doctor within a few days of the event. They may or may not have specifically complained about depression or suicidal thinking, but the sort of round of things that are going on in that person's life, their medical conditions, medications, the depression itself, all contribute to these factors. Depression also has an overlap with dementia. Severe depression may negatively impact cognition sufficient that sometimes a person may appear to have a dementing condition. In the past, the term pseudo-dementia has often been used. We've gotten away from this term because it implies that these cases are something that masquerades as dementia, and that may not always be true, because depression and dementia commonly do coexist. Both things may be valid and true at the same time. We know also that dementia may be complicated by depression. Unfortunately, recent studies have suggested that the medicines that we use to treat depression are not as effective in dementia as they might be in other situations. And there's a particularly interesting association between late life onset depression and dementia, particularly Alzheimer's disease. And it goes like this. If you have a depressive episode late in life, one way to divide that or categorize that is to determine whether this is a recurrence of episodes that have occurred earlier in life, in which case the connection with dementia is not very strong, Or is this a new onset, late life onset illness, in which case the connection with depression, with dementia is much stronger. And so some people have said that late life onset depression may be thought of as a risk factor for Alzheimer's disease. Our thinking now is beginning to say that it's better to think of late life onset depression as an early symptom of Alzheimer's disease. That is, the brain changes, the plaques and tangles and other brain changes of Alzheimer's disease probably predate the memory symptoms by a number of years. And during that period of time, you may see changes in speech and language, changes in personality, executive changes, and changes in mood that predate the memory symptoms. And that may be a more accurate way to think about it. We know that there is a genetic aspect of mood disorders. Twin studies and adoption studies show a fairly strong genetic link for mood disorders, particularly for bipolar disorder, where the link is stronger than it is for unipolar depression. Depression is associated with dysfunction of serotonin in relation to norepinephrine and dopamine. If I'd been giving this lecture 10 years ago, I would have said that depression is associated with low levels of serotonin. It turns out that's not necessarily true. The idea that low serotonin is the cause of depression turned out to be an oversimplification, and we're sort of in the midst of trying to refine our understanding of the role of neurotransmitter function in depression. But we do know that our medications certainly work largely in these systems. And serotonin, of course, is important in a variety of functions, including neurovegetative functions and also regulation of emotional balance and mood. Circadian rhythms are very important, and circadian rhythm disturbances may be a consequence of depression. For instance, changes in energy, diurnal variation of mood, early morning awakening, loss of sleep, and the like, and a variety of other changes that occur. And certain affective disorders, particularly seasonal affective disorder, may be directly related to disturbances in circadian rhythms. And also manipulating sleep patterns. That is, a person with major depression who is not permitted to sleep. So in an experimental condition, you might keep the person awake for a period of time. Often their mood dramatically improves. Mania can sometimes be triggered by the same thing, however. And so sleep is both a consequence of depression, sleep changes may be a consequence of mood disorders, but also may be involved in triggering mood disorders. Obviously, stress is related to depression. Stressful life events are strongly related to the onset of mood disorders, but stress is in the eye of the beholder. What one person perceives as stressful, somebody else may not. Even positive changes may be stressful. For instance, starting a residency obviously may be a positive thing, and yet it's associated with a high level of stress. Lots of theories about what causes depression over and above just genetics. Common theory is called learned helplessness, that's based on animal work and also some human work. This suggests that people become anxious and depressed when they have an attribution, that is, a belief about themselves that they have no control over the stress in their lives. So you may have a person, for instance, who is in a very high stress occupation, like a physician in a clinic would be an example, in which they have many, many problems to solve. But if that person perceives themselves to be the captain of their own ship, if they think they have the power and control to resolve these issues, it's unlikely that person is going to be depressed. It's much more likely that the medical records clerk, who may be a functionary, and they may perceive that more is asked of them than they have time or energy to accomplish, and that they have no control over their work setting, they may be very likely to be depressed. There's a kind of psychotherapy I'm going to talk about in a moment called cognitive therapy that's related to another theory of depression, and that has to do with negative cognitions or depressive attributional style. Attributions are the way in which people assign causes to events in their lives, and these negative attributions contribute to cognitive errors such as black and white thinking or overgeneralization or catastrophic thinking or the like. People who are depressed tend to make negative attributions that are internal. That is, they don't necessarily rely on external events. At a certain point, they become fixed in the person's thinking, and global. That is, they're exaggerated and tend to touch every element of the person's life. Such an individual will develop a pervasive sense of hopelessness and negative beliefs about themselves, about the world, and about the future. And this is certainly true of people with depression. What about treatments? Well, there are a variety of medical treatments. Antidepressants obviously are something that you guys know a lot about and already prescribe. In psychiatry, we also use electroconvulsive therapy and in recent years have used magnetic treatments called Rtms, repetitive transcranial magnetic stimulation, and sometimes other forms of somatic therapies. In terms of psychotherapies, a variety of things can be done. The two most commonly recommended forms of psychotherapy for depression include cognitive behavioral therapy and interpersonal therapy. Most of our medications increase levels of serotonin and or norepinephrine and ultimately result in a downstream change, that is, a downregulation of these systems over time. And they typically take time to work. So the direct pharmacological effect probably isn't the whole story. It's the system's realignment to the initial effects of the medication. These downstream effects seem to be important. Most studies suggest that about 2/3 of people that take medication get better, and the remainder don't. If you give them a second or a third medication, some additional margin of patients will improve, but you can never get to 100% improvement, regardless of how many medications you give. And the relapse rate after going on medications is fairly high. Generally, the longer the person's been depressed before they go on treatment and the more recurrent episodes they've had, the longer they should stay on medication as a preventive. Recently, there have been a lot of controversies that have been talked about in the press, and these have to do with re-examination of older studies in the form of meta-analyses. And some but not all of these meta-analyses have called into question the effectiveness of antidepressants. And I use the word effectiveness advisedly. It's not the efficacy that they're really calling into it, because efficacy as a statistical observation is what it is. Effectiveness is the idea that they make a difference in the person's life in the real world, over and above whether they're statistically significant. So some of the meta-analyses have suggested that particularly for people with milder forms of depression, antidepressants don't do a lot better than placebo. And it's an open question at this point. Psychiatrists obviously see a more ill group of people, and the evidence that antidepressants are effective is much greater for people with more serious forms of illness. But for the person in primary care, there may be a role for watchful waiting or referral for psychotherapy, or if an individual person is skeptical about medications, perhaps suggesting some other approach. I don't have a slide on it, but lifestyle changes, exercise, a variety of other things have been shown to be possibly useful. What kind of antidepressants do we have? Well, tricyclic antidepressants, monominoxidase inhibitors, SSRIs, SNRIs, and a few odds and ends that don't fit easily into other categories. Tricyclics you're not going to see very often anymore, but we still use them occasionally, especially for treatment-resistant cases. They block the reuptake of norepinephrine and to a lesser extent serotonin, and they include drugs like amitriptyline or Elavil that you may still see occasionally, and imipridine or tofranil. At one time, for many, many years, for generations, these were state-of-the-art, from the 1950s through the 1970s, almost into the 1980s. And they work very well, but unfortunately they come with a lot of side effects. They're strongly anticholinergic, they're strong alpha blockers, therefore they cause dry mouth, constipation, blurred vision, weight gain, orthostatic hypotension, and they may be lethal if taken in overdose. They cause cardiac rhythm disturbances. Monominoxidase inhibitors likewise were commonly used in the past, and now they're only used for selected cases of patients who've not responded to other forms of treatment. They block the monominoxidase enzyme, which normally functions to break down norepinephrine and serotonin, so-called monoamines, at the synapse, and so they increase the synaptic concentration of these neurotransmitters. Two examples include phenelzine or Nardil and tranylcypromate or Parnate. It's much less likely that you'll see these drugs in your practice. There's also Pernil or Eldeprel, a skin patch that you may occasionally see that's a variation on the same theme. The problem with monominoxidase inhibitors is drug and food interactions. That's why they're not more widely used. They may interact with other drugs, any kind of sympathomimetic drug, direct or indirect acting, other antidepressants like SSRIs or SNRIs, and also with foods containing tyramine, or large concentrations of tyramine. Tyramine is found in small concentrations in lots of foods and in large concentrations in foods that have been allowed to age. And these combinations can produce hypertensive crisis or occasionally serotonin syndrome. And so monominoxidase inhibitors now are sort of a niche drug. We use them in our depression center for very treatment-resistant cases, but in terms of general psychiatric practice, they're not widely used anymore. SSRIs are the most commonly used medication, arguably, and they do what the name suggests. They selectively inhibit the reuptake of serotonin. At one time, we thought that they were very selective, ultra-selective, and it turns out that's not really true. They do have effects in other neurotransmitter systems. Most patients find these drugs to be fairly benign, but a significant minority don't. So they may encounter physical agitation, insomnia, GI upset, sexual dysfunction, including loss of desire or sometimes anorgasmia. Ironically, there are also certain people that have anxious or obsessional preoccupations that interfere with their sex drive, and they may do great, better on SSRIs. So the common drugs, fluoxetine or Prozac, paroxetine or Paxil, sertraline or Zoloft, escitalopram or Lexapro, and citalopram or Celexa. There's also fluvoxamine or Luvox that you won't see very often. And these drugs are generally, unless they're combined with other drugs, not life-threatening in overdose. The SNRIs, the serotonin and norepinephrine reuptake inhibitors, are becoming more commonly used all the time. Some psychiatrists think these may be more effective or work faster. Most of us are skeptical about that and think that their overall effect is probably about equal to the SSRIs, certainly no worse. And these include venlafaxine or Effexor, desvenlafaxine or Pristiq. Arguably, some people argue about whether mirtazapine or Remeron should be in the same category, and duloxetine or Cymbalta. And then other antidepressants include trazodone or Deseril. It's not used for depression much anymore, but you may see it used for agitation and dementia or sometimes for insomnia. Nephazodone, the brand name is Surzone. Surzone was taken off the market in 2003 in the United States because of some cases of hepatitis. But the generic Nephazodone is still available. It's not widely prescribed, but you may occasionally encounter it. Very similar in its effects to trazodone. And the newest drug that's sort of in the same theme is vilazodone or Vibrant, which is similar to these other drugs. All of these drugs have very complex and somewhat difficult to succinctly describe serotonin, both in reuptake inhibition and also a variety of pre- and postsynaptic receptor effects. And then finally, the drug bupropion or Wellbutrin that now goes under a number of different names. It blocks the reuptake of both norepinephrine and dopamine. It doesn't have any direct serotonin effect. In that regard, it's unique among the antidepressants that we use. There's a major problem in our world, treatment-resistant depression, that is the person who's not responded to at least 2 well-conducted medication trials. It's very common. You may see different statistics about how common this is, but somewhere in the general range, perhaps 40% of patients with depression won't get better with medications of at least 2 trials. And we've come up with many different strategies for this condition, including combinations of antidepressants, usually but not always from different categories, like an SSRI plus an SNRI, or booster strategies like lithium, buspirone, thyroid supplementation, or atypical antipsychotics. And we could have an entire lecture on nothing but whether these do or don't work and what's the best way to use them. In terms of somatic treatments, ECT or electroconvulsive therapy is still used. It's used typically for depression that doesn't respond to other treatments. And for someone who's responded to ECT in the past, you may not wait and go through the whole round of treatments again. Psychotic depression and catatonia are particularly responsive to ECT. The exact mechanism of action is unknown, but we do know that for it to work, you have to have a generalized seizure. You don't have to have a physical convulsion. We block that with medication, but you do have to have a CNS seizure. And we have to give a number of treatments over a period of time. So typically 3 a week or so, and a total of 6 to 12 treatments. Although we don't predetermine the number of treatments, it's purely on the basis of how the person progresses. The main side effect of ECT is short-term memory loss. And I say that advisedly. It's short-term meaning that it doesn't last very long, and short-term with respect to the fact that it's mainly short-term memory that's affected. Rtms is repetitive transcranial magnetic stimulation. It's an outpatient procedure. It involves typically 5 treatments a week, 20 to 30 sessions of about 20 minutes each, so it takes about a month to do this. Does not induce a seizure. It's painless. There's no anesthesia. The clinical effects are roughly similar to ECT, and the exact mechanism is unknown. Probably not quite as effective as ECT. Unfortunately, it's not covered by insurance. It's very expensive. We do have a TMS machine here, so it is available. In terms of psychotherapies, cognitive therapy, it focuses on changing dysfunctional beliefs associated with depression. It's a structured form of therapy. In the interest of time, because we're running short, I won't get into all the issues, but it's not like traditional therapy. There's homework assigned. It's a collaborative relationship. We don't get into the unconscious. We look at a person's thinking processes and behavior in the here and now. And it's by far the best sort of researched, and there's most research supporting the use of cognitive therapy. Interpersonal therapy is a variation on the theme of traditional therapy, but instead of focusing on the unconscious or on the past, it focuses on interpersonal role disputes, relationships, and social skills. And it's manualized. That is, you can get a manual that tells you exactly how you should conduct interpersonal therapy. It's not nearly as widely available as cognitive therapy is. And commonly, we combine treatments. Some people believe, although the literature is a little bit mixed, that medication plus depression is more effective than either alone. Relapse prevention, clearly there's an edge to psychotherapy for that. Bipolar disorder, sometimes called manic depression, typically involves episodes of major depression and mania. The lifetime prevalence is about 1% for both men and women. You don't see a gender split in bipolar disorder. And the typical age of onset is late teens to early 20s. Inflated self-esteem or grandiosity, decreased need for sleep, pressured speech, flight of ideas, racing thoughts, distractibility, increased activity levels, and excessive involvement in pleasurable activities with the potential for painful consequences without any sense of the dangers involved, and an elevated, expansive, or irritable mood for at least a week are required. Several variations on this theme. Bipolar II disorder involves alternate episodes of hypomanic and major depressive episodes, but not a full-blown manic episode. And a milder form of bipolar II disorder is sometimes called cyclothymic disorder. Cyclothymic disorder is more chronic. The person has this as sort of incorporated into their personality, you might say. There's great variability in cycle time. Probably won't find two people who have the same kind of cycling. 35% of individuals go through only one cycle in 5 years. 1% of individuals go through a cycle every 3 months. Some people go through cycles every week. So-called rapid cycling bipolar disorder. Hypomania, that's when a person has elevated, expansive, or irritable mood for at least 4 days, same as manic episode, but to a lesser degree, but they don't have marked impairment, no hospitalization, and no psychosis. And hypomanic episodes may fly under the radar. That is, lots of people with hypomania may not reach the level of urgency where they show up in the doctor's office. Treatments, lithium is the best known treatment. We still don't know for sure exactly how it works. It works at a cellular level. The side effects include excessive thirst and urination, possible eventual damage to kidneys or thyroid, and the blood levels must be carefully monitored. However, the response rate is better than other treatments. Other approaches include anticonvulsant medications, for instance, valproate or Depakote, carbamazepine or Tegretol. These are primarily mood stabilizing, as lithium is, and anti-manic. They don't have any impact on depression per se. Lamotrigine or Lamictal is mood stabilizing and has a role in prevention of depressive episodes, but doesn't have any anti-manic effect. You also may see antipsychotics, especially atypical antipsychotics, and benzodiazepines used primarily for their anti-manic action, but also to a lesser extent for mood stabilization. And we try to avoid or use as judiciously as possible antidepressants for fear of provoking a manic episode or increasing cycling. But there are times when a person's in a deep episode of depression that you really don't have any choice but to use an antidepressant. Psychosocial treatments, family therapy, or other forms of supportive therapy or even cognitive therapy are useful in educating the person about the illness and increasing medication compliance and reducing relapse. And I think that's all that I have. And Dr. Spurgeon should be following up, but I don't think she's here yet. So you guys have any questions?
That's fascinating, Dr. Casey. Who had the idea of applying magnets to the brain for depression?
Who had the original idea? You know, I don't know the answer to that because TMS is not a new treatment. TMS has been around for about 30 or 40 years, and it was used experimentally. And we had a TMS machine here since the 70s. It was used in neurology and in psychiatry for a variety of studies. And TMS is not just one treatment. There are an infinite number of variations on the TMS theme, using different kinds of magnets, locating the magnets in different places, different frequencies of stimulation for different time periods. The kind of TMS that we have that we use clinically that's approved by the FDA is it's used in the left prefrontal area, and it's a high frequency, short bursts of high-frequency stimulation, the total treatment takes about 20 minutes, and it's very well tolerated. It's a good treatment. The problem is it costs about $8,000 to $10,000 to do it, and it's not covered by insurance. And you have to, there are disposables that you have to use that are extremely expensive. The machine itself is extremely expensive, and there's an operator that has to be trained to use it. So it's not a small outlay of capital, and unfortunately, it's an out-of-pocket expense. So it has not caught on. It really should be an alternative to ECT. So for most patients, I would think about this first and then ECT if this doesn't work, but it's not practical to do that in most cases today. But in terms of who thought it up to begin with, I really couldn't tell you. Any other questions? Yeah.
When you have somebody in the clinic and you do want to start an SSRI, obviously there's a number of them. Do you just have like a go-to one that you use, or what would you recommend?
So the question is, among the SSRIs, which one is better? Which one would I recommend? And the answer is that we cannot find any evidence that separates one from another in terms of their efficacy or overall side effect profile. One is as good as another. However, for most of us, it's easier to become very, very comfortable with one or two drugs than it is to become comfortable with every drug. And so for me, I would probably think about Celexa or Lexapro first, because I use them a lot and I know what to look for. Certainly in the past, Zoloft would be another example, and many psychiatrists would agree with those recommendations. But that's not the whole story. Most people who come to see me are not treatment naive. Most of them have been in lots and lots of treatment, and a lot of what I need to do is to take a very careful treatment history and try to determine what kind of treatment they've had in the past, how they've responded to it, what the pros and cons are. Sometimes the family history may be a little bit helpful, so look at the medications they're on. We also look at the specific symptoms, although the scientific evidence about matching drugs to specific symptoms is not very strong. But we still do it. For instance, somebody that doesn't sleep very well or lost appetite, you might think about mirtazapine. It's more likely to be helpful in the short run. In the long run, harder to make that case because the differences tend to even out over a period of time. But you do want to give the person as immediate relief as possible. So in my practice, I would imagine that I have prescribed virtually every medicine that you could possibly think of, because so many people come to me with these complicated medication histories in hand, and that is going to guide me in one direction or another. But let's take an older person who's treatment naive, and I'm going to think about starting them on an SSRI. I'm probably going to start them on a low dose of Lexapro or Celexa most of the time. A little caveat, even drugs that have been around for a long time that we think are perfectly safe, post-marketing studies sometimes reveal new wrinkles. For instance, in the last couple of years, the FDA has really taken a hard look at citalopram and Celexa and determined that higher doses are associated with rare but potentially dangerous rhythm disturbances. And so they've revised their dosing recommendations for older people twice in the last 2 years downward. So now we're really instructed not to go above 20 milligrams, and for most people, 10 milligrams. So you have to sort of keep up with changes. I have lots of people who are on 40 milligrams or 60 milligrams of Celexa. In a depression clinic, we may exceed doses that you would normally use. And we get into sort of an informed consent situation where we have to go over with the patient what are the pros and cons of exceeding this recommendation, knowing that they personally have struggled and they've found something that helps them, and they may choose to run that small risk. A question that often comes up in a lecture like this is, what is the role of the psychiatrist as compared to the primary care doctor? And I think I'll just address that question, and since Dr. Spurch is not here yet. Depression is so common that there's no way in the world that psychiatrists could treat all of it. So we make no pretense that that's what we ought to be doing. The majority of people with depression, particularly relatively mild or moderate levels of depression, are probably going to start with their primary care provider, and for most people that's where they should start. For people with very mild depression, I'm less likely to recommend medication today than I might have been 5 years ago, more likely to recommend watchful waiting, changes in lifestyle, psychotherapy. For people with moderate levels of depression, I probably am going to recommend medication. As we've talked about, I think it's perfectly appropriate for a primary care provider to take charge of that. When should you refer to the person to a psychiatrist? If the person has suicidal thinking, then really a specialist should be consulted. If you believe the person is psychotic or if they have bipolar disorder, that's complicated enough that it probably should be referred to a specialist. A person with treatment-resistant depression, a person who's you've given them a couple of medications, they haven't responded, that's a time that you might want to think about sending the person to a specialist. But for that leaves a very large number of patients who still are quite suitable for management in a primary care setting. Any other questions? Yeah.
Can you talk a little bit more about treatment failure? Do you try PCP has tried one SSRI? Do you have any general?
Yeah, there's a lot to digest about this, and we don't have complete consensus in our field about how to answer this question, but I'll give you my impressions. And the question is about treatment failure. If a person has been on an SSRI, most commonly used initial category of medication, at one time we believed that if they failed an SSRI, we ought to switch to a different category. Sounds perfectly logical. Turns out several studies have shown that that's not true. A person that failed on Prozac is just as likely to respond to Zoloft or Paxil as they are to Remeron or some other drug in a different category. So when they failed, if they're a partial, let me look at it this way. Suppose you give the person medication and they don't get anything out of it at all, and you're sure that they're taking it and they've taken a high enough dose for a long enough period of time, then you really need to switch to a different medication. If the person's a partial responder, that is, they have gotten something out of it and they're doing better, if they don't have any side effects, you may consider pushing the dose a little bit. Or that may be a situation in which you'd add a booster. And there's not a real clear literature as to which booster is better. You can take your pick, and it may depend on the circumstances of the individual case, their medical condition, and so on. But lithium or an atypical or Buspar or thyroid or what have you. And generally with boosters, if they're going to work pretty quickly. We call it an augmentation strategy. Another augmentation strategy is combination treatment, that is, one medication plus another. And typically people choose an SSRI that they're already on, and they'll add an SNRI or Wellbutrin, bupropion to it. But there's no rule. Another common strategy is to combine venlafaxine, Effexor, with Remeron, mirtazapine. Two drugs that are somewhat more similar in the same general category. Now, the science to that, I'm not sure I could say that there is a lot of science behind it. It's more trial and error. It's more empirical. There have been several studies looking at these questions. They haven't really answered all the questions for us. The largest study was the so-called STAR-D study that looked at a lot of these questions. And it suggested that there's some utility in switching drugs or adding augmentation, but there is a hardcore patients that are just not going to get better with medication. That this is not going to be a panacea for everybody. Okay. Any other questions?
Dr. Wright has tried to train us to use the PHQ-9.
Yes, PHQ-9. I took out my PHQ-9 slide because I had about twice as many slides in them. I figured there's no way I can get through all this stuff.
Well, we're trying to get into the AIM clinic, so whenever we have a depressed patient, we'll follow their PHQ-9.
There is a lot of evidence that using even very simple scales goes a long way toward improving quality of outcomes. It makes the diagnosis more consistent. It makes medication changes more consistent. You can track the person over time to a much more accurate degree than you can if you only have a narrative note. If multiple providers are going to see the person over time, it's much easier to track how they're doing. If you're taking a history and you want to know how they did when they were on a particular medication, you have something more than just the person's impressions, which may be very colored. Memories get very difficult for a person who's depressed. This negativism affects their memory of things that have happened in the past, so they may have negative attributions about past treatments that are not accurate. And so PHQ-9 is the simplest of a large number, and it's become I should say maybe it's becoming the standard. The PHQ-9 is not perfect. Some of the questions probably should be reworded. It's not a perfect way to follow suicidal thinking, for instance, but it is a lot better than not doing an objective test, and it is something that it's a little bit like the MMSE in that it's used all over the country, so you could talk to a colleague in some other place, they immediately know what you're talking about. Even though the MMSE has many, many problems associated with it, it's probably going to be phased out in favor of the MOCA or other things. and yet it has a certain utility as well. So the PHQ-9 is a very useful tool, and it's pretty easy to do.